Sir, Assalamu alaikum. Achha, Dr. Arif Saab has just joined us, so we shall start now in the
इंशाल्लाह
interest of time.
ठीक है बिल्कुल we are already late. I'm going to start. Thank you very much, sir. Bismillahirrahmanirrahim. All are welcome to this 17th JPOA virtual club Zoom meeting. I welcome you all. First of all, I request Sayyid Saad to recite from Holy Quran.
أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم قل هو الله أحد الله الصمد لم يلد ولم يولد ولم يكن له كفوا أحد صدق الله العظيم. Over to you, sir.
Thank you. Jazakallah, Saad.
Yes, sir.
I welcome all the participants and our expert panel for today, Professor Arif Khan, of this Zoom meeting of Journal Club of Pakistan Orthopedic Association. Today, Dr. Shazeb Baloch will present his original research article while he was a spine fellow at Ziauddin Hospital, Karachi. A topic of his presentation is intra and inter-observer accuracy of Cobb's angle in scoliosis 6 weeks apart. So today's plan is that, first of all, Dr. Baloch will present his article, and then we'll request Professor Arif Khan for his expert comments, and at the end, we'll open the meeting for all. If they have any questions, all the participants are requested to type in their questions, and then Saad will give them chance one by one and put these questions to Professor Arif Khan for his expert opinion, and author Dr. Shazeb Baloch. So I'll request now Dr. Shazeb Baloch to start his presentation, please.
Assalamu alaikum, everybody, and thank you, sir, for giving me this chance to present my article. So, as sir has already said, that the topic of this presentation would be its intra and inter-observer accuracy of Cobb's angle in scoliosis 6 weeks apart. So this was published in Journal of Pakistan Orthopedic Association, and the authors are Imtiaz Ahmad Hashmi, Mohammed Suhail Rafi, Saddam Mazar, Ataur Rahman, Iman. So the introduction is, we'll start off, and scoliosis is not just a sideways curvature of the spine, but in fact is a complex deformity of the spine, which is three-dimensional. Etiologically, it is classified under as idiopathic, congenital, developmental, neuromuscular, and tumor-associated as well. Scoliosis is considered to be the most common spinal deformity in children. Adolescent idiopathic scoliosis occurs between the age of 10 to 18 years, with a reported frequency between 0.4 and 5.2%, as quoted in the literature. To measure the deviation angle of a lateral curvature of the scoliosis in the coronal plane, and an angle of more than 10 degrees from the midline is considered to be a scoliotic curve. And it is a usually widely accepted method of calculating the Cobb's. So in order to measure the angle of deformity of scoliosis, Cobb's angle is used. So Cobb's angle is the angle between the most tilted vertebrae at both ends, superior and at the inferior end of the curve in the coronal plane of on a plane radiograph. For manual method of calculation, a pencil, a protractor are used, and the angle is measured using a goniometer. Digital methods of measuring Cobb's while using picture archiving and communication systems, commonly known as PACS, is debated to be more reliable in literature. Even currently in literature, they say that phone-assisted and ultrasound-guided methods are also in use. Even with the same end vertebra used as a reference, Cobb's measurement still varies by 3 to 5 degrees as quoted in the literature. Cobb's angle of more than 5 degrees in 2 successive X-rays examinations is criterion for progression of a scoliosis. So measurement errors such as inter-observer, variability range from 2.4 to 8.4 when measuring on the same radiograph at different intervals, as quoted in the literature. So why is this important? To have a proper Cobb's, or why to get the exact Cobb's, or at least near exact Cobb's measurements. So when calculating the exact angle, it is particularly important in diagnosis and severity assessment of the scoliosis and its curve, treatment planning, monitoring the progression or the regression of the curve, predicting long-term outcomes. Legal and documentation purposes are also very important. So while doing it, we had to look up the literature and we could not find any local researches. But currently, I just recently saw in August, there was a publication, but it was in a non-peer review journal. I'm not mentioning it because of it being non-peer review. It was the only article regarding Cobb's which I could find in the literature when it comes to Pakistan. Similar work was done elsewhere internationally on intra and inter-observers, reliability of Cobb's. Some were comparing PACS versus human, PACS versus PACS, computer-assisted versus computer-assisted, and phone-assisted as well. So the hypothesis was that the results may vary based on the experience of the observer, and having repeated readings with the same observer over a period of 2 to 3 weeks. The objective: the reliability in the determination of Cobb's angle depends on the technical expertise of the observer, as well as the correct angle measurement and determination of the end vertebra. So our aim was to find the inter and intra-observer variations while measuring the Cobb's angle on the same radiographs with 6 weeks time frame or a difference. So the methodology, what was our study design was, it was a prospective observational study. Measurements were taken by trained observers at 2 points, like between 6 weeks apart, for the intra-observer accuracy and inter-observer variability. So we wanted to see if the same reader was accurate enough, or was there any variability in the same person's reading 6 weeks apart. So 5 different readers were chosen, and all were with different years of experience to check the accuracy in terms of years of experience. So data collection, how did we do that? We took 39 radiographs of all AIS patients, and the study was conducted at Dr. Ziauddin Hospital, Clifton Campus, Karachi. The radiographs were taken from the patients who had visited our clinics from January till June 2023 during my fellowship time. Prints of the plain radiographs were taken. All observers were made to draw Cobb's angle on each of them separately on the same day. So everybody had to sit separately in a separate room, but they would draw it, and the same procedure was repeated at an interval of 6 weeks. Then the measurements were noted and were jotted down. So inclusion criteria: all patients with AIS who were diagnosed to be AIS, plain radiographs of whole spine standing views with PA and lateral views, and all age groups of patients with AIS who were diagnosed at AIS scoliosis. So the exclusion criteria: patients with previous spinal surgeries were excluded, degenerative scoliosis, congenital scoliosis, neuromuscular, even distorted or inadequate radiographs were also excluded from our data. So we had to do an observer training. So all observers went a standardized training program so that we could remove bias and get better accurate results. They had 3 classes and to enhance their consistency. The training included just simple review of the scoliosis anatomy, how to measure the Cobb's angle, and what are the landmarks that need to be taken, what are the measurement techniques, and how to draw an angle. And they were made to practice it, and this was just followed by uniform understanding of the application of the measurements protocols was implemented as well. So measurement protocols. Patients were positioned according to the established guidelines for Cobb's angle measurements, landmarks including the end plates of the most tilted vertebra, both the superior and inferior, identified on standing AP radiographs. Cobb's angle was measured between the lines drawn, again, repeating again, superior end plate of the vertebra above the curve and the inferior end plate of the inferior vertebra below the curve. So timings of measurement. Each observer took baseline measurements. Followed up measurements were performed by the same observer 6 weeks later. Observers were blinded by their initial measurement. So if reader 1 had taken
सॉरी आवाज गायब हो गई
Shadi, we cannot hear from you. So let me connect with him on WhatsApp. Maybe he has internet problems.
Yes, we all think so.
Yeah.
While we're connecting him, I also welcome our President of Pakistan Orthopedic Association, Professor Shoaib Khan, and our Secretary Lal Khan Kakar is also there. And I was also seeing our President-elect, Professor Masood Umar is also here. This is very good that all the seniors of Pakistan Orthopedic Association are attending this webinar meeting of General Club. Professor Arif, any comments up till the presentation till we connect him? I think he's here.
I'm sorry.
He's back here. Thank you. Continue, Dr. Baloch.
I'm so sorry. I hope I'm audible, and can you view my screen?
Yes, we can, and we can listen to you as well, please. Yes, please, you can speak, Dr. Baloch.
Is my voice audible?
Your voice is
Yes,
audible.
but we cannot see your
Can you
presentation.
share your screen as well, please? Your presentation screen. We can see your photo, but your presentation screen is not there.
Just let me try it again, sir. I apologize for this. I don't know why I'm unable to share it.
Sad, have you allowed him to share screen?
Sir, is it?
Yes, sir.
Can you see my screen now?
Yes, now we can see.
Yes.
I'm sorry. I apologize for this.
Yes, please continue.
So we used SPSS version 24. Results. All 39 radiographs were examined simultaneously by all 5 readers. So reader 1 was basically a spine surgeon professor with 25 years of experience. Reader 2 was a spine surgery fellow with 7 years of experience. Reader 3 was a senior resident with 5 years of experience. Reader 4 was a junior resident with 2 years of experience. And finally, Reader 5 was an intern or a house officer with 6 months of experience only. And then an interval of 6 weeks was taken. So comparison of mean Cobb's angle across readers at presentation. So we can see that there is significant standard deviation variation between reader 5, the professor, and the intern, which is 16 and 19. And we can also see that the mean difference is also 67.85 for the reader 5, the professor, with the years of experience, and 65 for the non-experienced one. Comparison of the mean Cobb's angle across after 6 weeks. So again, we can see that there is a significant difference and standard deviation variation, and the p-value is obviously insignificant. So intra-rater variability at presentation and after 6 weeks was jotted down, and we could see that the professor had excellent interclass correlation coefficient. It was because of the years of experience and came under excellent, whereas the intern was jolted down to good, as the criteria was because of the inter coefficient rate and confidence interval points. That's why they are in good and excellent, not in fair or anything else. So when we compare the inter-rater reliability, when we are comparing one reader to another, if we compared a professor with the fellow, there was a good ICC or interclass correlation coefficient of 0.98. And when we compare this professor with the reader, which is the intern or the house officer, we can see a significant drop, and it is of the ICC drops down to 0.74, which comes under fair. Similarly, again, a similar difference was noted between a fellow and the intern as well. And then if we consequently look at others, like the similarly professor with the junior resident, again, it was coming under grade good. It was reliability was good. And these were the results in comparing inter-rater reliability at presentation. Then again, we repeated the same procedure with 6 weeks apart. Similar results were seen, again, with no difference, with slight decrease in ICC, but it was insignificant then again. But it was very obvious that the years of experience compared to somebody with less experience, the reliability was very fair when comparing the same X-rays at 6 weeks apart. So when the raters were compared to their own X-rays after 6 weeks, so our reader 1, years of experience, we could see that the mean difference in Cobb's angle was only 2.3. Whereas if we go down and we can see the difference increasing, and the variability of the R5 reader, because of the less years of experience, shows that the difference in Cobb's angle after 6 weeks on the same radiograph was 10.15 degrees. So the mean difference when the raters were when the degrees were taken at the time of presentation, it could be seen that the reader 1 and reader 2 had a mean difference of 2.1 between their degrees. So, and there was a significant variation when it was checked as like reader 1 and reader 5. There was a 17 degrees variation in the mean difference. Similarly, 13.2 with the R5 to reader 2. And the other results are mentioned as well. Similarly, this was done at 6 weeks apart. Again, now when we checked it at presentation, when we were comparing their Cobb's angle at presentation, it was 2.1. But now when we look at it, it was 3.2. So then again, we could see that after 6 weeks, there is a variation again. Similarly, if we look at R1, reader 1 with reader 5, when we compare it, it is 17 degrees. And now it came down to 15 degrees. Then when we followed it up with the fellows, it was previously 13 degrees, and now it is 19 degrees. So it shows that after 6 weeks, there can be a difference in maybe measuring. We'll get to that. So a paired sample test conducted on the sample size of 31 was utilized to compute the mean differences of the Cobb's angles between presentation and after 6 weeks for each individual rater, with the significance level set at 0.05. The mean difference ranged from 2.3 degrees to 10.15 degrees, depending on the level of experience, with an average mean intra-observer was 6.41 degrees. The observed trend in mean differences among raters examined remained consistent, taking into consideration the experience level of each rater. It's noteworthy that none of the calculated values reached significant statistical significance, and which was obvious. Discussion. Evaluating Cobb's angle is crucial for assessing the progression of a spinal scoliotic curves in patients. It provides guidance for treatment decisions, such as bracing, surgical correction, and fusion. A shift of more than 5 degrees in consecutive radiographs typically indicates progression. So thus, it's very important to note them down. There is a recognized range of error during manual calculation of between 3 to 8 degrees, as mentioned in the literature. The inter-observer Cobb's angle recorded among raters ranged from 2.1 to 3.2, whereas the mean intra-observer angle ranged from 2.3 to 10.1 in our study. So manual techniques persistently find application due to their simplicity, cost effectiveness, which served as the underlying rationale of our study, even though there we can see that there is a huge difference between the calculations with inter and intra. Our results were similar to the findings of Hurtado Alves et al., Zuckerman SL et al., and Dang NR et al. These results signify that the role of experience level of the observers. Prior investigations focused on scoliotic curves within 20 to 40 degrees range in their sampled patient population. In the literature, their range of Cobb's was less. In contrast to our study, we had a very higher Cobb's angle, and as our mean was 67 degrees. Broader range of scoliotic curves analyzed can result in reduced relative errors. Our raters recorded mean Cobb's exceeding 40 degrees, as mentioned, 66.028 to 69.16 degrees, whereas in previous literatures, it was usually seen it was below 40s at presentation and even at after 6 weeks, indicating a predominance of patients with severe scoliosis in our patients because our patient population presents very late. Less experienced observers exhibited larger mean differences in Cobb's angle, surpassing the acceptable range of less than and equal to 5 degrees, as mentioned, which is signifying the change in the Cobb's degrees after 6 or whenever they do a follow-up visit. Substantial differences may stem from challenges related to image quality during Cobb's angle calculation, making it more challenging for an inexperienced observer to identify appropriate endplates on radiograph images. Observer 5, less experienced, showed a broader range of consistent Cobb's angle with more variability with a mean standard deviation of 19.11. Hence, our data was insignificant. Greatest range of variability was observed in inter-rater intracorrelation coefficient between professors R1 and the intern or the house officer R5 with the initial presentation of 0.748, and at 6 weeks it was 0.729. Caio et al. Documented that intra-observer ICC variability as 0.965 and inter-observer variability was 0.96, whereas our results were very diverse with an ICC of 0.98 for the reader professor and 0.79 compared to a 0.96 with when we are considering the interns calculations. So ICC ranging from 0.997 to 0.991 with similar experience level, but using different smartphones instead of manual method was expressed in the data. So it gave them a better accuracy, whereas we did manual. Pepe et al. Demonstrated decreased errors while measuring smartphone-assisted Cobb's angle, suggesting an improved accuracy of end plate, end vertebra selection. So in their study, they selected the vertebra, whereas in our study, we let the reader decide which end plate is supposed to be calculated. They were given the choice of deciding whichever end plate they deem as where the curve ends, hence resulting in our variability. Numerous studies conducted inter and intra observer analysis with a pre-selected end vertebra, potentially influencing the reliability of their findings. So then again in literature, it was mentioned that it is better to select the end vertebra and give it to all the readers. Hence, their variability was very low. Whereas compared to our readings, everybody had the free will to choose whichever end vertebra they deemed as the the most tilted vertebra. Hence, the diversity or the wide range of Cobb's angle. Our observer relied on the pre-selected end vertebrae, causing room for error. Other sources of error can include inaccuracies in measuring the angles or drawing lines. So it could have resulted due to the selecting the wrong vertebra. So if somebody had selected, let's say, just giving an example, T6, and the intern selected T5 or 7, that is why there was a huge difference in the Cobb's angle. Similarly, drawing of lines or the angles may be due to the tools as well. So the strengths of our study was that observers were being blind to the subject's information and not given a pre-selected end vertebra. So they decided to choose whichever. So, and the limitations, the use of individual and pencils rather than, standardized tools resulted in significant mean difference in ICC. Although this created a similar situation to a clinical environment, however, clinically acceptable reliabilities were only found in experienced observer. Factors such as use of wide diameter pencils and inaccurate protractors were identified as contributors to the adverse impacts on measurements. Lack of digital imaging is another limitation to this study. Furthermore, when employing Cobb's method, underestimation of 10 to 20 degrees can arise, as well as inconsistency of the angle interval. Conclusion of the study was observers' expertise level affects the Cobb's angle measurements reliability. The correct angle measurement and determination of the end vertebra is mandatory, which results in variation. Majority of raters intra-observer reliability continually maintained excellent or good, indicating that the same observer can repeat consistent measurements over an extended period. So less experienced observer, even though showed a wider range of variability, which highlights the difficulties in narrators encounter when determining the proper plates of the end vertebrae or the end plates on the radiographs. Inter-observer dependability, however, varied. Pairing with comparable levels of experience showed outstanding reliability, while pairs with notable disparities in experience showed fair reliability, as demonstrated in our results. So future directions. It is recommended that future research focus on improving the weakness and dwelling deeper into the accuracy of Cobb's angle measurements across a variety of demographic groups. This methodology provided a comprehensive framework for evaluating the intra and inter-observer accuracy of Cobb's angle measurements in scoliosis cases with a 6 weeks interval between measurements. These are the references. Thank you.
Thank you very much, Dr. Shahzad Baloch, for an excellent presentation. As you have concluded that ICC of 0.9 or more, which is good, is better in experienced hands. We have very experienced spine surgeon who have a vast experience of scoliosis and especially scoliosis surgery, Professor Arif Khan with us. So I'll ask for his expert comments on this paper, please. Professor Arif Khan, please.
Thank you, sir, for inviting me to be part of this session. And thank you, Shahzeb, for such a wonderful presentation.
Thank you, sir.
You expressed your knowledge and your experience very well. And I'm impressed with your presentation skills and the way you selected your topic and the way you handled your methodology and concluded your results. So I just have a couple of questions.
Yes,
As you rightly mentioned, that the reason for changes in the angle can be because of either using different set of equipment, or it can be because of choosing a different end plate, a different end vertebra. So I couldn't figure out from your paper the difference that you mentioned between different observers. What was the reason? Like from the professor to the internee, was it the change in the different end levels, or was it because of the equipment? And was the same equipment used by all the observers, or the same equipment used by one observer at 6 weeks apart, or they were different?
Sir, I'll jot it down. So what we noticed that it was mainly because when we were comparing the same X-rays of the let's say the intern, the reader 5, he in one of those X-rays, like let's say if it was X-ray A, he selected a different vertebra at 6 weeks interval. It was a very genuine mistake, which caused the increase or decrease angle in Cobb's. Mainly, it was because of the selection of the end vertebra, which was our results. I think I have missed out on this table. I apologize for that. But that was a significant finding that we found, that when you do not fix the end vertebra or the end plate, people tend to vary with angle because you give them the free will to select whichever you want. But when we looked at the studies, they had always, or most of the papers, had a pre-selected end vertebra. That is why their ranges were less as compared to ours. Secondly, second part of the question was that whether they use the same instruments, the pencil and the protractors. Yes, everyone, but inter-observer in the sense, I had mine, reader 2 had his, reader 3 had his, but they were not the same instruments or the same pencil or the protractor which was used by each, but it was the same used at 6 weeks interval. If I am not clear, I would like to repeat that. Everyone had their own set and they would use it at 6 weeks interval, but they did not use the same instrument. And that could have also, as I've mentioned, that could have also been one of the factors. But majority of our results were because of the end plate, choosing of the wrong end plate, which was left at the choice of the readers.
So in how many cases was it the wrong plate, and in how many cases it was the wrong measurement?
I don't have the table right now in my presentation, but it was most of the times. I do not remember the exact number right now,
Yeah,
but I do have the
because you
data.
see, what message that you are giving to the reader is to focus on the determination of the upper and lower invertebra. This is the message, isn't it?
Yes, sir.
So that we should be more consistent with selecting the levels. That is the
Yes,
most common mistake that people do.
yes, sir.
So unless this is clear that this was the rate between different observers, and the selection was persistent with this level of experience. Like for the professor, he selected the same in place, but for the intern, he
Majority of the
selected.
time.
So this mistake comes with experience, less experience, more in plate selection. My other question is, were they informed? They were not informed, right? That you selected this in plate in the first study and you selected this one in the second one. While they were doing the second observation, they did not know which end plate they had selected previously.
Yes, sir. So none of the observers knew what was the angle they calculated, what end plates they chose, what was the apex, what was the, it was randomly given to them. We wanted to see if the same reader looking at the same X-ray chooses the same vertebra or the same angle comes out. And most of the times it was noticed that because there were 70, mean there were, everybody had their own, the sets were printed out and they were already given a number like A, B, C, D. And nobody knew what was A except for the statistician who was present, and he knew that what was the first and what was the second. When the results were calculated, then only we found out that who had calculated what and what end vertebra was chosen by each observer. Initially, they were all everybody calculated, handed over it to the statistician, and it was an easy process. But we could see the obvious mistakes being made by mostly the inexperienced person choosing the wrong vertebra on the same X-ray at a different interval most of the time.
So my next question is, the experienced observer who had experience and who chose the same invertebra with the same set of instruments and with the same X-ray, what was the reason for the change in the observation?
So this is again a question which was I looked up in the literature. It is noted down in every paper that even if they choose the same end vertebra, there will be an mean difference of 2-3 degrees at least. That could also lead to the size of the lead pencil, the thickness, the instrument, or even while, sometimes when we are calculating, we become too rash and we go on, draw a line, and then sometimes human error, if I may use the word. So this was what was mentioned in the literature, that it is possible. So we wanted to find out whether it actually is a thing. So that's one of the reasons.
So can we get this inference from your study that if experienced people, instead of using the manual method, they use digital one, they will minimize this difference in the angle?
So if we look at the literature and what I've gone through, the results were better when they had a fixed end plate and a digital method was used, like PAC system, computer assisted. So it would draw the line itself and would give you a better line. When it comes to human, we tend to make a bit, our lines, either the thickness of the lead or the pencil which is used can make a difference in 1 to 2 degrees. And it can also, when we connect those two lines, that also can lead to the difference. So we wanted to see that if that is the case. But in our scenario, when we look at our systems, 90%, or I don't want to be using that word, but it's a hard reality. Most of the people don't have access to the PACs at clinics. They have the access only to the hard copy of the X-ray. So it can be limited or it can improve our mistakes but it is suggested or recommended to use computer assisted and a selected or pre-selected vertebra when we want to make changes. So if we are looking at the same patient 6 months later to see if the curve has progressed, we should always identify that if we had taken, for example, T7 as the superior vertebra, we have to take that vertebra. If we change it, then again, the difference in angle would be very significant.
Okay, so that brings me to my next question. You see, as you said, not many people are using the PAC system. The PAC system is available only in academic institutions of excellence. But scoliosis is done only in higher yielded academic institutions. It's not done in periphery hospitals. It's not done in the small street hospitals. So
Yes, sir.
most of the centers where scoliosis is done, they have the PACs. So, and this is what the future is, and this is what the present is. So why you went to the past, like the procedure which was developed 30 or 40 years or 50 years ago, and which have been used and which is now obsolete in the world? I mean, how many centers in the world are now using manual x-rays? And you are still going in the past and analyzing the same method, which is now no one using. Instead, you could have done the same exercise with the PAC system, because this is the one which is nowadays used for scoliosis determination.
Yes, sir. Sir, I actually wanted, uh, this was a question which was asked to me when my paper was published by one of my friends. He said, why don't you use the computer assisted? I said, there are certain things as called as realities. When we are in the clinics, I have seen I've worked in a lot of institutes, so I have seen that when those x-rays come onto the table of the clinic, most of the patients are not inpatient, they come as outpatients when we are observing their, after 6 months just to see if there is progression or regression. So what happens is 90%, or I don't know how many people are there who would actually take the time out and put it on the PACs and take out the angle. But majority, or as I've seen in my practice, I have not seen one person doing that or taking out the Cobb's angle using a PACs. So I just wanted to see if our reality, because we live in Pakistan, we tend to believe in our skills, or most of our consultants is availability, time availability, even patient flow. If there's a big line, we do not want to go and open up the PACs and calculate those angles, but we tend to look at our x-rays, previous x-rays 6 months back. We see, okay, this is T7, इसी पे draw करके मैंने angle निकालना है. I was just trying to imitate a real life scenario which happens in our day-to-day basis, even though scoliosis is practiced in a tertiary care with high-end facilities, but still, whether it's fortunate or unfortunate, we tend to still stick to our manual calculations. This is unfortunately a hard reality, and I've seen it in my practice. And that is why I wanted it to be more realistic based than to just calculate, because PACS again, system पे 3 महीने पुराना X-ray खोला नहीं आ रहा. So that is also one of the reasons we need a lot of time to advance, unfortunately. But this is the main reason why I wanted it to be more realistic, even though this is an kind of outdated, but still practiced uh, uh, clinically how to calculate the Cobb's angle. This is unfortunately what we do in reality. And so that's the main reason.
So in that case, I think one of your recommendations should be to use PACS instead of the manual methods, because
Yes.
in majority of the cases, it's just the laziness of the surgeon. The system is available in most of the institutions where scoliosis are done. So
Yes.
it just the laziness of whoever is measuring it. So one of your recommendations should be that we should be using PACS every time we use COPS for decision-making process. Just one small query.
Yes.
What was the rationale behind the 6 weeks interval?
I had seen in papers they usually used 3 weeks, 1 month. So I just wanted to increase it to 6 weeks. I discussed it with my professor. He said, let's not be the same what they do. Let's increase the interval. Most of the intervals which were used were 2 weeks, 3 weeks, or maximum was 4, which I'd seen. I don't know, maybe there was 6 weeks, but I'm not sure. So we wanted to, just increase the duration to see how much of a human error is possible. Because we do not, whenever a patient comes to us, our follow-up is a minimum of 3 months or 6 months, as a matter of fact. So we do not measure it at, and also the other reason was that during my fellowship, I needed to complete this. So I needed to choose a time frame. So the time frame which I thought was long enough and accurate enough was 6 weeks instead of 6 months. But I had
Do
not
you
seen.
think
Yes,
do
sir.
you think if we change this interval to maybe instead of 6 weeks, we make it 6 months? Do you
Okay.
think the results will be the same or they would be different?
I believe it would be different because the human error, it just shows it's very evident. Unless it could be the same because of our results and what I've seen in literature. If you're experienced, years of experience, there is no replacement for it. So years of
That's fine.
experience.
But we are using the same observers, the one for which you use the 6 weeks interval, and whatever results have come out. Do you think if we change this interval from 6 weeks to 6 months, would they produce the same difference or would it be different?
Most probably it would be different. I mean, the same results as which I found. They will be
Same or
diversity.
different? I'm confused.
Different in the sense that, let me just rephrase myself. Same results as I've published, that the ranges would vary. They would be larger, or there would be variation in angle.
Okay, so in this case, then can we get this impression from your paper that is the human measurement depends on the duration on which they check the same X-rays, and therefore the humans are just not capable of measuring it, and we should be using some computerized system which they can do, because if the same human, while doing measurement on the same X-ray using the same equipment at different intervals, if they are drawing different observations based on the duration between the two readings, then it's the problem with the humans. Then it's not the problem with the angle. It's not the problem with the methodology, the problem with the human. So that would be a totally different uh, result. I think this would not be correct.
So this is just my assumption because I just wanted to see if it was possible. Because time durations, I mean, our results are not what we have seen in most of the papers. They have very close variability, whereas when it comes to our results, it is the variability is high. So that could be one of the factors. One of the factors could be experience. One of the factors could be time. One of the factors could be selection of the vertebra, and even the how tired is the professor or the attending while calculating those angles. That could we have that problem. But when it comes to PACS, even though when I've looked at the literature, when computer assisted is calculated, it still gives that variability as well of 2.1 degrees. It does have that. That is also because then again, we select those angle while we are drawing it on the end plate.
Correct, but it should not depend on the duration between two observations.
Okay, sir. Maybe, sir.
Because if you are giving that impression, then the same professor with the same experience, with the same X-ray, with the same tools, it's
Okay,
just the difference in the interval. Why should he be drawing different angles?
I stand corrected, sir. I agree.
So thank you very much. This all from my side, Rana sir.
Thank you very much, Professor Arif. You have asked him all the questions. I must appreciate Dr. Baloch, the way he has answered, although there was many limitations in the paper, which we do understand in our world, it is there. I do not know whether at his institute he have a PAC system available or not, and soft copies of footage X-rays are available. But I think I'll ask you, in this era of artificial intelligence and machine learning, now most of this work is done at the computer. I agree with this, right? But for beginners like me who doesn't do spine surgery, is there any apps are available on mobile phone which are free and easy so people can use it? Yes, Professor Arif, what you think? Is there anything
Yes,
available?
yes, there are apps. There is one app which is actually very excellent, but you have to subscribe to it. But again, it's the man behind the gun that matters. So whatever app you are using, it's the man behind the gun who matters. So is the same person is using computers or assisted or better magnification and these things, he will minimize his own errors. But if someone with different experience, if someone doesn't know how to choose the invertebra, there is no tool and no machine in the world that can give him the same result.
Right.
So
Thank you.
no match for experience.
I do understand. So it's the same thing. The money and the man behind the gun makes the mayor go, right? And now we have
Exactly.
Professor Masood Umar, our president-elect, have raised his hand. Saad, can you open the mic for Professor Masood Umar? And please, Professor Masood Umar, you can do your question.
Yes, Assalamu alaikum, and thank you for this opportunity. I really enjoyed the discussion before the presentation and then the discussion. So as a non-spinal surgeon, purely from understanding perspective, my question was, why were we comparing professors with interns? It's too vast a difference, and usually the clinical implication of any research paper is how this now information and results need to be applied clinically. So if I'm to operate on a scoliosis, if I were to be for a minute a spine surgeon, I would not rely on anybody else's measurements like the tumors I do. Final measurement on the day of surgery is done by myself on all patients, right? And my residents do that, give me calculations, and I kind of verify that by my own calculations. So I guess all spine surgeons also do that. Nobody would be relying on their interns or junior residents to calculate their angles for them and to do a significant surgery by just a junior person measuring. So that's the two parts of my questions. Why were professors compared to interns? Maybe you answered that. I missed that. And what would be the clinical implication? Thirdly, when I do deformity correction, even on packs that we have, if I'm doing it repeatedly, I do get a variable result, like 2 degrees difference or a 3-degree difference or a 4-degree difference in the Cora that we calculate on, for example, deformity work, which is again packs-based calculations. So even with this experience that I have on deformity correction, if I do it 1 week apart, maybe I have some difference on a PAX also. So the X-ray versus PAX, and now even PAX is there's nothing perfect about it. If it would depend on where I draw the line, where I select the center of the distal femur and the center of the proximal tibia. So that all human variation always exists. And to me, that would not make a big amount of clinical or disturbance in my decision making or the final outcome of the patient also. I'm sorry for being too long. Thank you.
Thank you, Professor Masood Omar. It will be very difficult for Dr. Baloch to answer all these questions because Professor asked him to do this research, and as a fellow, he has to do something. It's a very good contribution, right? He cannot say. But we agree with you, Professor Masood Omar, that if in experienced hand, if the difference is less than 5%, then it's not statistically significant. And he has already said that the difference was slightly more than 5%, which was statistically significant in junior hands. Ideally, it should be done by the surgeon and by the experienced hands. And that was his research. He did this. And that's what I can say. I can bail him out in this one, right? And otherwise, he has defended very well. You want to add up anything, Dr. Baloch?
Sir, I would try to answer it. I'll try my best. But so the thing is, we wanted to see the diversity, how accurate it is. Sometimes when it comes to documentation purposes, an intern enters these degrees. Sometimes they calculate it when they're enthusiastic. And this is one of the reasons why we added the intern. Because Ziauddin Hospital is a spine center, Clifton campus. So most of the interns, they do calculate it and they do the documentation work, which is checked by the residents. And sometimes I've noticed the resident who checks it just signs on it, never actually corrects them or never calculates or bothers. So we wanted to see how accurate or, how worlds of experience can actually make a difference, or is it actually a thing? So, and the other thing which, sir, I would like to add, which sir asked, was that even 2 degrees in spine, it would be slightly different because 5 degrees, more than 5 degrees variation on a consecutive X-ray is kind of significant for somebody who's doing scoliosis. So that is why we wanted to see whether this variation actually exists, even if I'm doing it via PACS. And what I've noticed that when we are using the PACS system, we tend to select the wrong angle, or sometimes we click on the dot. We are unable to, we're either not fluent, or maybe our PACS system is not that great, or maybe we are not that worse with the usage of the PACS. Sometimes I've noticed that when we are calculating the end vertebrae by same end vertebrae, while I'm doing it on a manual system and comparing it with the PACS system, I do see a variation. And I feel more comfortable. I used to feel more comfortable with the manual system because I thought it was done by my hands. But after reading and going through all the literature, I think PACS was more accurate than me. And the reason, I think I forgot the other parts of the question, or I hope
think
I've answered.
you have said very well. So digital things are PACS system is better. Number one. Number two, the more experienced you are, the less chances of these differences there. Thank you very much. And we do have our Secretary General, Pakistan Orthopedic Association, Dr. Lal Kakad Sahab. Any comments from him, please?
अस्सलाम वालेकुम
Walaikum
सबको
assalam. Dr.
Assalam.
Kakar,
सबको
please.
सबको वेलकम कहता हूँ। हमारे जो सीनियर असातिज़ा है अरिफ खान साहब, आप फिलावेज साहब, मसूद उमर साहब, बाकी सारे दोस्त, अगर किसी का नाम मैं नहीं ले लूँ, आई एम हैप्पी दैट at least we have started by Zoom the general club regarding our topics. और मैं बहुत खुश हुआ शाहजेब, क्योंकि मेरे कोयटा से हैं और इसने इतना अच्छा प्रेजेंटेशन किया, कॉन्फिडेंस के साथ, सुकून के साथ, और बहुत अच्छे आंसर भी दिए। और प्रोफेसर अरिफ खान साहब को, और अरिफ खान साहब ने भी अच्छे अच्छे सवालात किए टू इम्प्रूव द फर्दर आवर प्रेजेंटेशन एज ए टीचर। हमारे अरिफ खान साहब और मसूद उमर साहब का बात भी मैंने सुन लिया। तो मेरे फाइनल कमेंट्स है, वी शुड कंटिन्यू दिस जनरल क्लब मीटिंग बाय जूम। और साथ साथ मैं थोड़ा सा जनरल क्लब से हट के भी बीइंग रिस्पॉन्सिबल एज ए जनरल सेक्रेटरी, हमारा एग्जीक्यूटिव बोर्ड का मीटिंग होना था कोयटा में, और वो भी थोड़ा सा प्रॉब्लम का शिकार हो गया। और साथ साथ हमारे जो मौजूदा प्रेसिडेंट है वो भी जरा तोखान में भी प्रॉब्लम कर रहे हैं। तो अगर ये चाहिए फोरम मुनासिब नहीं है, क्योंकि लिखने पढ़ने का फोरम है, इवन देन अगर आप लोगों से थोड़ा सा इनपुट मिल जाए, आई विल बी थैंकफुल टू यू, फ्रॉम आरिफ खान साहब, फ्रॉम दिलावेज साहब, फ्रॉम मसूद उमर साहब और दीगर दोस्त जो बैठे हुए मीटिंग में।
थैंक यू डॉक्टर लाल खान काकड़, वो हम प्राइवेट पे ले लेंगे। तो ये जनरल क्लब है, तो अब एक मीटिंग हम साथ को कह के अगर अरेंज कर लें, आप कह दें तो वो फिर हम उस पे ले लेते हैं, या किसी को पर्सनल इनबॉक्स कर दें, वो ले लेते हैं। नाउ आई रिक्वेस्ट प्रोफेसर मोहम्मद शोएब खान, हु इज प्रेसिडेंट ऑफ पाकिस्तान ऑर्थोपेडिक एसोसिएशन, फॉर हिज कमेंट्स प्लीज।
Actually, sir, he has left. He has messaged me. Due to signal, he cannot continue. So he is not yet with us.
चले चले लाल खान, तुम्हें आंसर मिल गया, ठीक है। ही इज नॉट।
ओके सर, थैंक यू सर।
ठीक है, thank you very much for all the participants, my senior, junior colleagues, and our expert panelist, Professor Arif Khan. And I must appreciate Dr. Shahzeb Baloch, you, because you have defended very well. These were difficult questions, although relevant to your paper, Professor Arif Khan asked, but you have done very well. This is appreciable from the Journal Club, from Pakistan Orthopedic Association. Right, and I appreciate the efforts of Syed Saad, who organizes all these things, because without his help it not been possible to get all these people on board to announce dates and then to organize. We are thankful, and we are also thankful
Thank you,
again
sir.
all the participants for participating it. Thank you very much. Inshallah, we'll see you at Journal Club.
Thank you, sir.
Thank you, sir.
जनरल
Thank
क्लब
you, sir.
Thank you very much, sir. Thank you very much.
Thank you, sir.
Thank you.
Allah Hafiz.